Okay, I think we'll get started now. It's 1 o'clock. Welcome everybody to this afternoon's Southwest Cancer webinar. Sorry, I'm getting quite a lot of feedback at my end. I'll carry on for now. So today's webinar is on head and neck cancer and rapid diagnostic centres. This has been hosted by the Merton Training Hub in collaboration with Southwest London Cancer Team, Kingston and Richmond, and I'll be hosting this afternoon. So welcome to you all. This is the third in a series of 6 cancer webinars that have been organised, and this slide will be put up at the end as well. If you'd like to sign up for the future programmes, then please do. Just like to start with a few big thanks really to the team involved in putting these together. So Zara from the Merton Training Hub, Ekta and the rest of the cancer team who have been really instrumental in putting this together, as well as RM partners and of course our consultant speakers for the afternoon who have made this possible. Just a few housekeeping points before we get going. So please make sure your microphones and cameras are off throughout the webinar unless you're speaking. And we will be using the chat function, so we want to make this as interactive as possible. So do use the chat box for any questions and comments that you may have, and our team will be replying in the background. Time permitting, we should be able to have some questions and answers in between speakers and towards the end, so please use the hands up function for that. As much as we want to make it interactive, please try to resist the temptation to take control of the slides, because this will affect what everybody sees, including the speakers. The webinar is being recorded, and the recording and the slides will be available on GP TeamNet and will be sent out via the training hubs afterwards anyway. And an evaluation link will also be sent out and available to you. Everyone's feedback is really valuable, and so please do complete that, and you'll be able to get your certificate of attendance as well that way. Great, many thanks. Next slide, please. So this is the agenda for the afternoon. We've got some really interesting topics and speakers on head and neck cancers and rapid diagnostic centres, also known as RDCs. I'll introduce the speakers as we go, and we'll do our absolute best to keep to time this afternoon and allow time for questions and answers. Next slide, please. So I'm just going to talk briefly on the impact of COVID and the head and neck services, and also introduce RDCs to those of you who may not have heard of it. So this slide just illustrates the number of 2-week referrals that have been generated for head and neck and all tumour sites from April to August. As expected, there was a big drop in the month of April compared to the same month last year due to COVID. I think it was around 35%. But as we can see, this is steadily recovering to a level of about 90% now in head and neck. And this was confirmed at the end of October to be just above 90% for the same time last year. Next slide, please. So this slide just illustrates the numbers of head and neck cancers diagnosed via 2-week wait referral for the months of April to September this year, as compared to the pre-COVID monthly average, which is shown by the red dotted line. So on the whole, we're probably still tracking a little bit below where we were in pre-COVID times. Next slide, please, Ekta. So I think with that in mind, it's important to recognise that with the referral numbers creeping back to normal and activity going back to normal, head and neck services have probably been disproportionately affected by COVID, given the nature of the aerosol generating procedures that they do. Much estates work has been undertaken at the Trust to ensure that activity is safe for patients and staff, and to be able to increase capacity to meet the rising demand. I'd like to also mention that head and neck referrals are now being clinically triaged to ensure that patients can be safely triaged to the most appropriate clinic for their first contact, whether that may be face-to-face, virtual, or even a straight-to-test. And with that in mind, I think it's really important to stress the point that the quality of GP referrals is really crucial for that safe triage to happen, as well as the amount of information that goes along with the referrals. From a primary care perspective, I think we've seen that the number of referrals we're making is rising. Patients are more readily presenting back to us now in the last few months, and so I'd just like to point us in the Pan-London forms for head and neck cancers haven't changed in the last few months in light of COVID. As we've seen with some of the other tumour pathways, the head and neck criteria have stayed the same for GP referrals. We have access to See the Signs, which is a really useful, really intuitive tool, which is embedded in our clinical systems, and we have access, all GPs have access to that in South West London. It can be used as a decision-making aid, as well as a referral aid, and it's also got a safety netting function built in, which is also really useful. So for any practices who aren't using it, I would really recommend having a look at that. So just a little bit about RDACs. So this may be a new concept, rapid diagnostic centres. What are they? Broadly speaking, there are two types of RDACs. We have non-site specific RDACs, which we'll be hearing in much more detail about later on this afternoon. And that is the sort of thing that GPs might use to refer into patients who have vague symptoms. We're worried they may have a cancer, but they don't fit cleanly into a 2-week pathway. And then we have the site-specific RDACs. The example I'd like to give is the Kingston Hospital Head and Neck Lumps and Bumps Clinic. This has been running in conjunction with RM Partners for about 4 years now. Essentially, it's like a one-stop shop. It brings together a multidisciplinary team of specialists in radiology, head and neck surgeons, pathologists and endocrinologists. Patients that are triaged to this clinic can expect to be assessed. They can get a ultrasound-guided FNA as well as a consultation, and with accelerated reporting, they may even have their outcome by the end of the day. The clinic has been running for 4 years, as I say. It's been really successful and has had really good patient feedback. I think our next speaker will be talking a little bit more about this in detail. So I think that I'm going to stop there and introduce our next speaker. So warm welcome to Mr. Enye Offo, consultant ENT and head and neck surgeon from St. George's in Kingston. Over to you.
Thank you very much, Atin. I hope you can all hear me clearly. Well, Atin, can you hear me? You can do a thumbs up. Great. So I think the focus of my presentation is really just how we can improve on the head and neck cancer referral into secondary care. And as you're probably aware, head and neck cancer is not as common as some of the other solid tumors that you encounter, such as breast and lung, but it does contribute to a significant proportion of the oncology workload, and it's also a complex site to manage in view of all the consequences that treatment has on function and long-term survivorship. It is a mixed bag because it does include cancers of the thyroid, salivary gland, as well as the mucosal tract within the upper aerodigestive system. But the vast majority tend to be squamous cell carcinomas. And what you need to know is that men are more likely to be affected, twice likely to be affected as females. And in terms of the age distribution, whilst it still peaks in the older population, as I mentioned before, men more than women, we are seeing a trend, increasing trend of head and neck cancers in the slightly younger age group, and I'm talking about the 40 to 60-year-olds. So it is worth considering that. And you can see from this slide as well that 25, 30-year-olds also get head and neck cancer. So you shouldn't exclude those patients into secondary care if they have symptoms that might be concerning just by virtue of the fact that they are under the age of 40 or 30 or 40, for instance. Next slide, thanks. This just illustrates the subsites, various subsites, and the proportion of cancers that we get from those regions. The oropharynx tends to account for probably around about 40 or 50% of our current workload. The nasal cavity, nasopharynx are less common, but you should always consider those subsites depending on the patient's presenting symptoms, which we'll cover in a little bit more detail. You also can see that prevention really is the key here. About 46 to 86% of head and neck cancers are potentially preventable if patients don't smoke or they reduce their alcohol consumption. HPV risk obviously is, if you've been exposed to it in your earlier life, there's not much you can do about it, but we're hoping that with the HPV vaccine that is being rolled out to not just females, but also to young boys, over the next 20 to 30 years, the incidence of certain types of head and neck cancers that are predominantly HPV driven should hopefully go down. Next slide, thanks. And this just illustrates some of the risk factors that we've kind of touched on. There are a few which may not be as obvious. Betel nut chewing, for example. If you've got someone who's a woodworker and they've got sinonasal symptoms of, persistent epistaxis or feeling of oral fullness, pressure in the ear, then that could indicate a sinonasal or nasopharyngeal cancer. Salted fish is shown in the bottom right corner, particularly Chinese-style salted fish. Is a higher incidence of nasopharyngeal cancer in certain patients. So, for example, a 40-year-old male of Chinese origin with a neck lump or persistent nasal or ear symptoms, you should strongly be considering nasopharyngeal cancer. And then there's radiation exposure as well for thyroid cancers. Next slide. And I've put this slide up really just to touch on symptoms, and you can see there is a long list of symptoms that could indicate a potential head and neck cancer. But the important thing to bear in mind is that these symptoms could also reflect benign disease, and most of the patients that will come to you with a blocked nose or with epistaxis or a sore throat do not have head and neck cancer. So how do you tease out the ones that need to be referred on for further assessment? I think the key thing you can see from this slide is a neck lump runs as a common theme for all the various subsites. And some of these subsites, unfortunately, you will not be able to examine in primary care to ascertain if there is indeed a primary tumor there, as, for example, the nasal cavity and the nasopharynx. So I hope the take-home message from this slide is that anyone with a neck lump that's persisted with no sort of predisposing factors of an inflammatory episode, i.e. they've not had a recent upper respiratory tract infection, then especially if they're an adult, you should really be escalating onto secondary care for further assessment. And that's where the RDACs have been very useful, because with the neck lump clinics, they get an initial clinical assessment, they get an ultrasound scan, and a biopsy if necessary. Some of you may have access to ultrasound scans in primary care, and that's fine because, depending on your index of suspicion, you may decide to go down that route. But if there are other symptoms, for example, persistent hoarseness and difficulty swallowing, in addition to a neck lump, then those patients really need to be referred in as an urgent 2-week wait referral. Next slide, thanks. And in terms of the various subsites in the oral cavity, the tongue's reasonably accessible. Patients will notice that they've had an ulcer which has persisted. They may have some bleeding from it. They may have persistent pain in the mouth, a loose-fitting denture. In those situations, you really should escalate their referral into secondary care using the 2-week wait pathway. And again, a neck lump in the context of a non-healing ulcer, that should also raise the index of suspicion. Next slide, thanks. As far as the larynx and hypopharynx are concerned, so they're obviously a bit more difficult for you to examine because you really need to perform a flexible nasoendoscopy to visualize those sites. Persistent hoarseness is a very common symptom. The conversion rate from your referrals from primary care into secondary care just for hoarseness alone is actually very low, because most of the time it's due to muscle tension dysphonia from people who excessively use their voice. However, in the context of a smoker and persistent symptoms, and especially if they've got a lump in the neck, again, you have to be worried that those patients may have a laryngeal or hypopharyngeal cancer. You can see in the bottom right corner, that picture there, that's a hypopharyngeal tumor. It has a lot of room to grow before the patient may actually have any symptoms of dysphagia. That patient may actually only have otalgia as their complaint. So persistent otalgia in a smoker, they're at risk of a hypopharyngeal cancer, that really should be escalated on for further assessment on the 2-week wait pathway. Next slide, thanks. So this is just a quick case presentation, a patient with a neck lump, 41-year-old, non-smoker, non-drinker, lump for 8 weeks with no other symptoms. In terms of what you'll do next, you would want to examine them, I'm pretty sure. So if you look in their mouth, next slide, thanks. You may see an appearance like this, where they have an abnormally enlarged or asymmetrically enlarged right tonsil. And this, in the context of a neck lump, should raise the index of suspicion that this patient may have a tonsil cancer. They could also have a lymphoma. But I would strongly encourage you to send these sort of patients down the head and neck pathway as opposed to the lymphoma pathway, because we're very adept on the head and neck side to direct patients down appropriate pathways if, for example, this doesn't turn out to be a squamous cell carcinoma, but instead a lymphoma. One of the things we use the ultrasound and biopsies in clinic to do is to help us determine what further imaging we need to get. So in this context, a patient with a neck lump, and you may look in their mouth and the tonsils look slightly enlarged, asymmetrically enlarged, or you're not entirely convinced that it is indeed tonsil cancer, we can settle this very quickly in the one-stop clinic, because if they have a biopsy from that neck lump and it shows squamous cells, then those squamous cells must have arisen from somewhere in the lining of the upper airway digestive tract. So it can't be a lymphoma, it must be a carcinoma. And on that basis, we can then refer them on for the appropriate tests. If, on the other hand, the biopsy shows lymphoid cells or cells that belong in the lymph node with no evidence of epithelial cells, then that would suggest that this is a lymphoma. They may have B symptoms, weight loss, night sweats, fevers, but not necessarily so. But the fact that this biopsy is able to discriminate between a lymphoproliferative process or metastatic carcinoma is very useful, because the pathways are very different in terms of further imaging. Next slide, thanks. And this is just to illustrate the sort of changing demographics. So on the left-hand side of the slide, tonsil cancers we used to see in elderly males who were heavy smokers, heavy drinkers. Now we're seeing it in much younger patients who've never smoked, never drank, and supposedly there is a risk from sexual transmission, or so the number of oral sex partners that your patients may have does influence their risk of HPV infection and oropharyngeal cancers. I don't know how many of you take a sexual history from your patients. I tend not to spend too much time on that, to be honest with you, because by the time they've come to me with the cancer, changing sexual practices isn't going to make much difference. But that's a conversation. You can ask me questions in the chat box later as to how to deal with that subject. Next slide, thanks. So thyroid cancer, if we just go back one, so we're seeing a lot more patients with thyroid cancer. The question here is this truly reflecting an increasing incidence because more cancers are developing, or does it just reflect the fact that we're doing more imaging, ultrasound, CT scans, and picking up cancers that may not have been a problem if we'd left them alone? We can't put the genie back in the bottle. Next slide, thanks. And what we recommend, if you have a patient with a thyroid, if you're convinced it's originating from the thyroid, because clinically it appears to be the case, we would say get some thyroid function tests. If the thyroid function tests are abnormal, then this could represent a hyperfunctioning or hyperfunctioning goiter, in which case endocrinology referral is more appropriate, and they can always refer back into the thyroid surgery service if it was felt that there was a malignant process going on. However, if the thyroid function tests are normal, then really you should be referring them on to the head and neck team to exclude thyroid cancer, and they need an ultrasound. Whether or not you decide to do this ultrasound in primary care, you just need to be fairly comfortable that you can interpret the results that come back to you because the radiology result may need to be nuanced or interpreted with a bit of caution depending on the patient's presenting symptoms and risk factors for thyroid cancer. So anyone with risk factors, anyone with compressive symptoms or cosmetic concerns with a normal thyroid function test and a goiter, you should refer on into secondary care. Next slide, thanks. So I've just put this up so you can understand that you really, if you're going to do your own ultrasounds in primary care and act on the result, then you need to be getting this information from your radiologist. And if they don't give you a U grading, then you need to ask them why, because this is the gold standard. And it just allows us to quickly interpret what to do next. If a nodule is benign, U2, then you can consider reassuring and discharging your patient unless they have any of the other issues, for example, history of thyroid cancer or compressive symptoms. U3 nodules need to be biopsied. Obviously, U4, U5, you need to be referring them on quickly. Next slide, thanks. Consequently, if they have a biopsy, you also need to be able to interpret the result. If it's benign, that's reassuring. You can consider discharging them. Indeterminate nodules upwards, suspicious and malignant nodules needs to be referred on for further management because of the suspicions of thyroid cancer. And essentially, you can go back and look at this. You need to think about guidelines which are readily available. And this is what we use. The British Thyroid Association haven't updated this from 2014. But if you've got a patient who's asymptomatic, the nodules are benign, with no clinical suspicion of malignancy, you can discharge them in primary care. If the nodules have benign cytology and benign ultrasound appearances, then you don't necessarily need to repeat the biopsy unless there are clinical suspicions of cancer. If, on the other hand, the nodules are benign on cytology, but indeterminate or suspicious on ultrasound, then you really want to repeat the biopsy before you discharge the patient. And this is for those who are considering taking this on themselves in primary care. It's just to avoid a situation whereby you get false reassurance from either a benign biopsy result or a benign ultrasound, and you really need to put the two together in the context of the patient's clinical history as well. Next slide, thanks. So just a few things on COVID. It's obviously been a challenge for everyone for various reasons, more so for you in primary care. We have found that from the fact that a lot of our procedures, both in terms of basic ENT examinations or using flexible nasal endoscopy or aerosol generating, it did make it a bit difficult at the beginning to assess patients safely. I've just put this up to say that we would still encourage you to examine your patients. I know there's been a big drive, a big push towards telephone consultations, but what we have seen is we saw that, as Atin pointed out, there was a drop in 2-week rate referrals. That obviously is coming back up to normal, but we're seeing a lot of patients who've not had an initial face-to-face consultation in primary care. And consequently, a lot of those patients don't have concerning or cancerous pathology going on, and we are discharging them. They probably could have been discharged, or you may not necessarily have made that referral if you had seen the patient. So this is really just to say, we would strongly encourage you to see your patients, but do it safely, obviously, if you're going to do that. Next slide, thanks. Yeah, this is, again, is just highlighting the disadvantages of telephone consultations. You may miss subtle examination findings, such as oral mucosal ulceration or cervical lymphadenopathy. And it also can be a barrier for those patients who are not as technologically savvy in terms of getting access to healthcare. So we still need to try and maintain some degree of face-to-face assessments in both primary and secondary care. So just to give you some insight, we moved a lot of our initial consultations in secondary care to telephone. A lot of patients who are coming in via primary care referrals, for example, things like sore throats, were going straight to tests. For CT scans, for example, we were getting a lot of negative CT scans from the perspective of laryngeal or hypopharyngeal cancers, but we were picking up a lot of insignificant incidental findings. So that was creating a lot of additional work. And it meant that the CT scanner just could not cope with the additional work, when a lot of these patients, if they were seen face-to-face, would not have been sent for any imaging. So consequently, in secondary care, we've had to come back to what we were doing pre-COVID, which is to insist that everyone is seen first before they are sent for any imaging. Next slide, thanks. And this is just an appeal to say, as you can see, the 2-week wait referral forms haven't changed for a long time. I think this is the 2017 version. If you can give us as much information as possible, it will really help us in terms of being able to stratify patients into low versus high risk. Just to give you some idea of numbers, across Southwest London, there are about 6,500 plus 2-week wait referrals. The conversion rate, i.e. the number of patients from those referrals who actually turn out to have head and neck cancer, is actually less than 2%. So 98% of those patients do not have cancer. However, they still are a significant resource. They do have an impact on the system, in that it requires not just being seen by a clinician in secondary care, but it also requires a number of investigations in the process. So for that reason, we say, look, if you can give us as much clinical information as possible, we can pick out those patients who are at a higher risk of having head and neck cancer, so that those 2% actually get identified and managed in a timely process, and the 98% still get seen and sorted, but the 2% don't lose out as a result. Because if we just get a tick that just says patient has a lump, it doesn't really help us in stratifying them. Next slide, thanks. And this is just to end on the RDC clinic that was set up at Kingston with the help of the Royal Marsden partners. They were very, very helpful in that context with regards to the funding. We have a consultant, ENT or head and neck surgeon, and a radiologist and pathologist. We've found that we had a 69% increase in referrals from previous work that we were doing, and it's been a fantastic resource. Patients love it. Especially in light of COVID, we don't have to bring patients back for their ultrasound scan and biopsy. They get a diagnosis on the same day, and that can guide additional imaging. And we're actually working towards having spare capacity in CT and MRI, so that on the day, patients can actually go from this clinic into the CT scanner and have any additional tests that need to be done. We have made it available to everyone. I'm sure my managers at Kingston won't be very happy that I just said that, but I think if you have got access on the ERS to refer into it, you can do that. Next slide, thanks. And this just shows you that 93% of patients were very satisfied with it. When we first started it, we found that 36 patients were diagnosed with cancer through the clinic, which kind of the conversion rate is what you'd expect. We're struggling to keep up with demand, but we're working on getting additional capacity. Thank you very much. Next slide. And I think in summary, I think we've kept to time. You just need to recognize that head and neck cancer, whilst it is uncommon, and most GPs probably won't see that many patients with head and neck cancer in their sort of career, but you need to try and sort of tease out those patients who you need to worry about from all the ones whose signs and symptoms reflect benign disease. I think the way to sort of identify patients who are at greater risk of having head and neck cancer is those with persistent symptoms and those with risk factors. You really need to be referring those ones on. Be aware that oropharyngeal cancer is now a disease we're seeing in younger patients who've never smoked, who've never drank. So do have that at the back of your mind. And finally, you just need to be familiar with the current British Thyroid Association guidelines on how to manage thyroid nodules. I think that's pretty much it.
Great, thank you very much, Enya. That was really helpful and very interesting. We've got.
Sorry, Anton, I think you're on mute.
No, can you hear me? Can you hear me okay? No, can anyone hear me?
Yes, I hear you.
Okay, Enya, can you hear me?
We can hear you.
Okay, I don't think Enya can hear me. We have one question in the chat box, and we've got a bit of time. We've got 5 minutes at the moment to do some Q's and A's. So please do put some questions in. I'm just going to message him. There was a question earlier on from Rosie Savage. Enya, can you hear us?
Atin, can you hear me? Because I can't hear you.
Yeah, I can hear you. Can you hear me? Okay, maybe I think we're having a little bit of technical difficulties with Enya's sound. The question from Rosie Savage will ask when we get him back. If anybody else has any questions, please do put them in the chat box now. Okay, we have one more. Let me see. Anya, can you hear us?
We can.
Sorry, I'm just going to try to get through to him in a minute. Okay, we'll come back to this. I think let's move on and do the questions towards the end. If we could get the next slide, please, Hector. Thanks very much. So I'm just going to introduce the next agenda item. So I'd like to welcome Dr. Anna Mary Young, consultant medical oncologist from St. George's, and Dr. Owen Carter, who's a Wandsworth GP, program lead for cancer in MAC GP, as well as being a GPSI in oncology, who are going to be talking to you about rapid diagnostic centres. So over to you, Owen and Anna Marie.
Brilliant, thank you. Just to amend them, we've got a slight change. So Fiona McCarthy is joining me rather than AM Young. So I'm just going to give an overview first of all in terms of the RDC, and then at the end Fiona is going to add a little bit of information as well, and hopefully some time for some Q&As. So just a bit about the Rapid Diagnostic Clinic and for the service here at St. George's. So first of all, in terms of why it's been around, why it's started, is that we know that cancer is becoming more common. 1 in 2 of us will be getting cancer if we've been born after 1960, and we know that actually the cancer outcomes in England are some of the worst within any economically developed country, and so we really need to improve sort of a timely diagnosis as well as ideas in terms of prevention and screening. And often we know that actually patients may not fit down a simple 2-week rule pathway, or they may activate several at the same time. And as GPs, it can be really difficult in determining, what's best for the patient. How can I actually get this patient investigated quickly? Who I have, I'm concerned there may be an underlying suspicion of cancer. And we do know that for people who have a gut feeling, for GPs who have got a gut feeling of cancer, the data actually shows a really quite high conversion rate of those becoming cancer, about 8 to 14%, depending on the types of studies you look at. And so what we've set up at St George's is a clinic where we've got the generalist overview, where there's a clinical concern of an underlying cancer, but that patient doesn't fit down a single 2-week rule pathway. So importantly, if a patient is activating a normal 2-week rule pathway, we'd want them to be referred down that specialist pathway. This is more in terms of sort of the general non-specific concerns. And this was modelled from the Dutch. They've had a similar healthcare system as to ourselves, and they had a similar outcomes in terms of those late diagnoses of cancer. And they have set up these sorts of clinics and actually shown that it does improve the early diagnosis of cancer. Just in terms of a little bit of a glossary of terms, I wanted to mention that there are some variability in what these clinics are called. So the national spec is called RDCs, Rapid Diagnostic Clinics. We've added in an extra C here at St George's to be highlighting that actually these are for suspected cancer patients. But indeed, there is the ADOC clinic at Chelsea Westminster, the Acute Diagnostic Oncology Clinic, which has been running for the last few years. And that's very similar, and it's on the similar spec to the RDC. Next slide. Yep. So so I said this is our national RDC model. I won't go through this slide in much detail, but just to be showing that hopefully we're looking at early identifying, having something that's timely referred, and then a broad assessment of symptoms, coordinated testing, and then timely diagnosis of those patients' symptoms, and then an appropriate onward referral. So what we were looking for is sort of taking ownership of that patient and seeing them through that pathway and referring on to the appropriate specialist at the end of them, or discharging back to the GP. Okay, next slide. So just a bit of information in terms of what's going on at South West London level. So that now in the next few years, we're seeing these rolling out nationally. Locally, as I said, we've got the ADOC clinic, and for that is mainly for the South West London area, only sort of accepting Wandsworth referrals at present. But there is the ADOC clinic at West Middlesex, which works closely with the Chelsea Westminster site, which has just opened, and these and they have Richmond referrals are accepting from now as well. There are discussions and talks at Epsom, St Helier and Croydon and Kingston in terms of services that they will be looking at as well. And over the next year or so, we may see the development of those services. For the St George's site, we're looking at we're about to launch. We're formally launching to Wandsworth from January, and we will be accepting a few referrals before then. And I'll send out some comms closer to the time. Okay, next slide. So in terms of that, the St George's Clinic, as we said, we're calling it the Rapid Diagnostic Cancer Clinic. So it's a clinic where patients can be seen quickly, have that holistic overview, and that will include psychological assessment as well. So we closely work with one of the clinical psychologists with a specialist interest in cancer. So if we are concerned as GPs that actually there may be a strong psychological element to their symptoms, or indeed that actually we are concerned that they may not be attending appointments and following up on appointments, they need that extra support. On our referral form, we have a tick box to say actually we want that the psychological input as well. The patient is then triaged by phone, via ANP, and then investigations are organised, and then a face-to-face review is then made once we've then after they've had their remote consultation. As we said, it's not for single 2-week rule pathway patients. Please refer those onto the normal 2-week rule pathway. And yeah, we've got a setup here of GPs, oncologists, generalist ANP, as well as more sort of general medics and more specialist teams. What I would advise is to look at see the signs to ensure the correct use of the pathway. So from January it will be activated. It's not activated at the moment within the pathway, but for Wandsworth it will be from January, and the ADOC clinic is currently live for Wandsworth as well. So where it's suggesting that actually it's activating more than one 2-week rule pathway, or there are these vague symptoms suggestive of a cancer, then it will be recommending to be referring on to a clinic such as ours. Okay. Next slide. So there's the referral criteria. I won't go through that in detail. I've discussed a number of them already. It does include where we've got incidental findings of a disseminated malignancy of an unclear origin. We've got bony lesions of a lightly malignant origin as well, where there's the absence of a clear primary site. that unintentional or unexplained weight loss with that clinical suspicion of cancer, and again, where it's not meeting referral for an alternative tumour-specific pathway. There always has to be that clinical suspicion of a possible underlying cancer. So there is an ask though in terms of primary care level as GPs, we need to be making sure that we're investigating these patients appropriately as well. So it is always important to be thinking about what type of investigations we need to be doing. So that would include routine bloods as listed there. And often actually these patients are vague, so they may have weight loss and nothing else. So it's important to be doing a chest x-ray and also a FIT test. So FIT is not available in secondary care. It can't be organised at secondary care level. So us within primary care need to be organising and following that up. So if that could be done as well. Our referral form does have this all information in as well. And also when you check it on See the Signs, it will discuss it as well. Okay, next question. So what I wanted to talk briefly were just some case studies based from the ADOC model actually that there was some shared learning of. So this first one, this patient had direct access CT pancreas organised by the GP because there was some weight loss and abdominal symptoms. And just to highlight that we do have increasing amounts of direct access imaging, just be within your different boroughs, just checking what's available. Again, See the Signs will have that information for you as well. So this patient was had a CT pancreas. They were referred to a upper GI two-root pathway because there was an abnormality found on the pancreas, and all that was advised is interval imaging. But nothing else was done in terms of looking at possibly other causes of where this abnormality may be coming from. So the patient then attended A&E a few weeks later, and they had a chest x-ray, which actually showed a large lung tumour. So again, just highlighting the need to be having that kind of looking at the whole patient and doing the chest x-ray and a FIT test. Okay, next slide. So the next study was a patient with non-specific weight loss, no other symptoms, but a background of type 2 diabetes that had multiple referrals to multiple teams. So they'd been investigated, I think, by 3 or 4 different two-week rule pathways. And actually, when they were reviewed within the ADOC clinic, it showed that actually that actually was the patient was overusing their insulin, and that was the underlying cause. Another patient was for fatigue and weight loss, but chronic raised inflammatory markers, again, was seen under lung, upper and lower GI pathways. All of that was normal, and actually underlying cause was PMR. So actually, again, thinking that these patients often will have significant pathology, even if it's not cancer. Okay, next slide. So then this patient was a 35-year-old woman who presented with vague abdominal pains. An ultrasound of her abdomen showed a non-specific abnormality within the liver. And this is a patient I saw actually, and we referred on for an urgent CT abdomen. So it was referred to ADOC, and that revealed a very large intestinal tumour. Okay, next slide. So that's just kind of an overview of the RDCC here at George's and some information about it. And we're going to briefly just hand over to Fiona to discuss a few things before we just do some Q&As.
Hi there. So I am Fiona McCarthy. I am one of the consultant oncologists here at St. George's, and I'm also the clinical lead for the Rapid Diagnostics Centre. I just wanted to briefly touch base with you and just explain our kind of thinking behind the RDCs and really how it will work when the patients do come to hospital, so you guys have a better idea of what to, I suppose, managing expectations for the patients. Now, in terms of where RDC was born from, so the NHS longer term plan, one of the key criteria is faster and earlier diagnosis of cancer, as we all know. Now, the plan is that by 2028, approximately 75% of patients will be diagnosed with stage 1 or stage 2 cancer. And as part of this earlier diagnosis and faster diagnosis, rapid diagnostic clinics were the answer to this. Now, we do know that out of all the patients nationally that are referred to rapid diagnostics clinics, only 8% have cancer. Now, this is better than the 2-week rule, which has a kind of translation of about 4 to 5%. Hence the reason there is a lot more of an emphasis now on the rapid diagnostics referral pathway. but 92% of these patients won't have cancer, and we here at St. George's are a rapid diagnostics run by oncologists. Now, we are pretty good at treating cancer. We are probably not the best at general medicine, hence the general medics and GPs on board, but that's just something to bear in mind, that you are referring to a cancer exclusion service, and that it is primarily run by oncologists. Now, I think that, obviously I'm quite biased, but I think the rapid diagnostics here at St. George's is truly innovative in terms of even rapid diagnostics, because we have Owen as part of our kind of key leadership structure, and we really, really want to merge primary and secondary care. We know that our existing models of care in terms of working with GPs and the way we work isn't really working. You guys are often frustrated by the kind of lack of communication from hospitals and vice versa. So I think we're taking the opportunity with rapid diagnostics to try and improve the diagnostic pathway and relationships with GPs in Southwest London. So we also have a psychologist, as Owen said, on board. And, you know, if you guys are worried about somebody, whether you think there's a significant psychological component, whether you feel there may be some social issues or psychological issues that may stop the patient presenting, or any issues like that, you contact us, you let us know, and our psychologist can do remote sessions with the patient if the patient is agreeing to that, to try and smooth the pathway as well. Now, I will kind of I think somebody earlier mentioned that RDCs, or certainly maybe the head and neck RDC, was a bit of a one-stop shop. We're unfortunately not a one-stop shop for cancer. What we're trying to do is obviously pick out the patients that do have cancer, but we need to make sure that the patient pathway for the 92% that don't have cancer is pretty smooth as well. So I think it's probably quite useful to talk through what we will do and what you guys will, how you guys will refer. So using See the Signs, you can refer the patient directly to the nurse triage clinic via ERS. There will be about a 3 or 4 day turnaround. So at the moment we're officially a 2-week rule pathway, but for an unspecified amount of time, we push back. So as you know, with the 2-week rule pathways, you refer and they have to take it. We don't, simply because this is a new service and a new way of working. So if we don't think the referral is appropriate, we can contact you and say we are not taking the referral. That is, we are trying not to do that because that's not in the patient's best interest. But as Owen said, if you have something like say somebody who hasn't had a fit test and has abdominal symptoms, obviously we cannot do that in secondary care. We will push back on that. So you are concerned about the patient, they have vague symptoms. On ERS, you book them into the RDC clinic. The first contact that the patient has within 3 or 4 days will be a telephone triage appointment with an advanced nurse practitioner who is actually a general medicine background. Now, this is, first of all, it's really important to tell the patient this is not just a kind of a quick appointment. It's 45 minutes to an hour. She will go through everything. We have a ridiculously long form for anybody triaging to go through, looking at every system and every sign, and it's quite holistic as well. To be fair, it's looking at every part of the patient's family history, journey, everything. What will happen then is the ANP will decide on some investigations and discuss the patient with the consultant of the morning or the afternoon, and then those investigations will be ordered. We have a pathway coordinator who will then try and minimize the amount of time that the patient actually has to be in the hospital and try and get all the investigations within a day or the same day or two, so the patient doesn't have to repeatedly come up over a week. And then when those investigations are done, and we're hoping of a turnaround time in terms of like imaging, like CT scans, of about a week, then the patient then gets booked in by our pathway coordinator to see a consultant. Now, at the moment, because it's an oncology delivered service, you have approximately about 5 oncology consultants delivering the service. We will hopefully have 2 GPs, Owen and another GP. We have 1 session from a general medic. We have 1 session from gastro and 1 session from care of the elderly. So longer term, we will try and kind of move, if we think it's a more general medical issue, we will obviously try and book that patient into the general medical person's clinic. But in the initial stages, it will be everybody seeing everybody. The patient then if it isn't cancer, if it is, okay, first of all, if it is cancer, they then get put in the appropriate cancer pathway here, and we can do that straight away. It doesn't necessarily, it won't be a case of referring back to the GP to go on a 2-week to re-refer. If it isn't cancer, and this will be the majority, what we have, the options are, if we don't think there's any serious pathology, we will refer back to you guys. If we do think there's a serious pathology and we think it's a cardiac, rheumatology, or whatever, we have developed a kind of one-stop shop outlet, and that these patients then can be triaged from us, and they will go straight to see the specialist that they need to. And these specialists have already come on board and agreed to see these patients in their kind of hot clinics. So ideally, that even the patients that don't have cancer will still be fast-tracked. Now, that isn't to say that you refer in anything that of patients who don't have cancer because you think it'll be fast-tracked. I know probably won't do that anyway, but it's just saying that we've kind of staked our reputation as oncologists, saying that we're not going to refer on just anything, just to get the people in faster. And we kind of ask you guys to help us with that as well. Then in terms of what we're going to do, we're going to open up to Wandsworth in January, February time, or January. We're then going to open up to Merton, hopefully by the middle to the end of February, with a plan to open up to Kingston and Richmond by May. And I think there seems to be a lot of questions coming in, so I'm happy, myself and Owen are happy to answer any questions now as well.
Thanks, Fiona. So yes, so if there's any questions, do let us know. In terms of questions that have come on the chat, in terms of discussing referrals, absolutely. So we're just finalising the mobile number that you will be able to speak to the coordinator about, and we would want it as a learning experience for in terms of both sides. So yeah, if there's queries you're not sure, then absolutely it would be, you know, with our comms once we launch formally, I'll make sure that's clear in terms of how you can get in with us. Yes, in terms of so in terms of exclusion criteria.
So, well, sorry, I have the referral form in front of me. The exclusion criteria is, just need to make sure that it's over 18 and that they have a performance status of 1 or 2, and that they're actually physically able to attend the clinic. And also the most important thing from our point of view is please just to inform the patient that they may have cancer. What we will do, and this will come through in the comms, is that when you book in the patient to the advanced nurse practitioner clinic, you will be able to give them a patient information sheet on the RDC there and then. But we just want to make sure the only criteria for us basically is that they know they may potentially have cancer.
Great. Were there any other questions that anyone else had at all in terms of the for the RDCC?
So Owen, Martin here. There's one question from Mawani Shazma. Who can refer to Rapid Access Clinic at St George's? Just local GPs, or also the rest of South London? So yeah, so as Fiona was saying, so initially from January it's going to be for Wandsworth only, and then over the following kind of 6 months we're going to gradually open it up across to the other boroughs within southwest London. So as soon as when it's activated within your borough, we'll make sure that comms are sent out to make that aware, and also be active on See the Signs as well. And just something else coming through, as I mentioned before, in terms of the acronyms can be a bit confusing. So ADOC, RDC, RDCCs. So basically they're very similar. We have our factors, but fundamentally these are vague symptom pathways where there's a clinical suspicion of cancer, but they don't fit a usual two-wall pathway. Yes, and what's now happening with ADOC, which is the Chelsea Westminster Clinic, which has been running for a few years, is they are now just about to release a referral form as well. So it's quite clear in terms of the types of patients that they will be accepting, and they do accept. So yeah, but they're fundamentally all of a very similar model, but we're just kind of working them out locally. Okay. Any other queries? If not, we'll one's just come through. Can we decide on using one acronym, please?
Well, Yes, it would be much more easier. And what we're also trying to do is have a single referral form as well, because I think otherwise it just muddies the waters. It's there's about 3 different or 4 different names for RDC throughout London, and it's not ideal. We now, all along, we've all been kind of essentially working in silos. Over the last kind of 2 or 3 months, we're now part of a pan-London RDC panel, and we will try and clarify that. It is just trying to, obviously, it's a slightly political issue to try and keep everyone happy.
And just in terms of the question about when will the form be available on See the Signs, so once we're live, so from January it will be live on for Wandsworth. It will be live on See the Signs. Okay. There looks like there's a head and neck question for the next one. I think it's or do you want me to just talk about?
Would the RDAC clinic be able to see a head and neck referral for a nasendoscopy, I think is the question.
So is that for Mr. Offer?
Yeah, the answer is yes, if you're concerned the patient may have cancer. So they just need to have the usual 2-week wait referral form sent in.
So I think the question is, would the RDAC take a referral for this? But I think the answer to the question is no. That you would make that referral to head and neck.
Absolutely.
Not the RDAC.
Yes.
Yeah.
Yes, that's right.
Yeah. Great.
Okay. Perfect. So if that's all the questions that we had, I just wanted to just summarise from what we've discussed and the support available for the general South West London team. So as we've mentioned, See the Signs is now active within all South West London boroughs and has been recently updated, has talked about all the entire spectrum of cancers and particularly things that we can be doing at a borough level. So in terms of what investigations are available to us and the pathways that are active as well. All adhering to the Pan London guidance, which does differ slightly from the NG12 NICE guidance. Also, there's some support and advice from Cancer Research UK. Christine Young, who's the facilitator for South West London, welcomes practice and PCN visits. And there's some links here within the slide pack which can be available to you shortly. And then just in terms of the other South West London cancer webinars, as we've got listed there, the next one is on the 26th of January on personalised cancer care. And then on the 23rd of February, it's on upper GI and lower GI cancers. And then we've got the final one on the 24th of March on prostate and lung cancers. And just to say thank you for listening. If you are able to click onto the Survey Monkey and give us some feedback, and for any queries or a copy of the presentation, please do contact the South West London Cancer team. The email address is there. I think that rounds us up.
Great, thank you very much, Owen, and thanks everyone for joining us and listening, and thank you again to all our consultant speakers. Yeah, so this brings us to the end. I think Owen's sped up a little bit, so just got us in there in time. So thank you very much, and I think we'll draw the webinar to a close.
Great.
Have a good afternoon.
Thank you very much.
Thank you.